Hey guys, welcome everyone to the Medit. Here we will be taking a quick review of respiratory medicine for upcoming FMGE exam, primarily focused on the important topics. Obviously, we're not getting into the details or conceptual understanding. Obviously, we would have all prepared through last few months to understand the concepts better. This is just a quick retake on whatever we have learned so far. Okay, so from respiratory medicine, what is important? There are two major topics, which is asthma and COPD, and there are some emerging topics. One of them is the sleep disorders, and then 𝐒𝐄𝐝 65. 𝐒𝐿𝐝 65, I think all of you are familiar with all this course, and in the last year for the FMGE, I had done a separate module where we had discussed about scoring systems useful for medicine. I will share that notes again on the Telegram, go through that, and that should be more than enough. We will focus today now on asthma and COPD. This is expected to take maximum 20 or 30 minutes. After that, we will have a break and then we will restart with the cardio revision, which unfortunately we couldn't do yesterday because of technical problems. Okay, so what is important from asthma? First thing that is important from asthma is classification of asthma into type 2, non-type 2, on what basis and how do we classify. And then how do we initially manage a case of asthma? Means once we diagnose asthma, how do we initially manage? Another important expected topic for MCQs is going to be the biomarkers for type 2 asthma and the role of biologicals or monoclonal antibodies in the treatment of asthma. Standard template had been how to differentiate between asthma and COPD. For several years they have been asking that question, interpretation of PFT to differentiate between asthma and COPD, that we will definitely learn. Okay, next topic is going to be COPD. From the COPD, it is mainly the risk factors, certain named clinical findings, image based questions are possible, diagnostic criteria and gold guidelines for the management of COPD, right? So let me start with asthma. What is asthma? Asthma is a disease of small and medium airway. It's an airway disorder. It is not a parenchymal disorder, which is characterized by reversible obstruction to the flow of air. So it is a reversible obstruction. In COPD also we have airway obstruction, but that is persistent obstruction. That's the most important point that we need to remember. How to differentiate between COPD and asthma? By proving that asthma patients have reversible obstruction. So whenever someone has asthma, what clinical features they will present with? Generally they will present with cough. With cough, often they have scanty sputum or no sputum. It is not copious sputum. Whenever someone presents with copious sputum, we think of conditions like bronchiectasis, lung abscess, right, or chronic bronchitis. So in COPD, chronic bronchitis, they present with large quantity of sputum production. Asthma, scanty or no sputum. Along with that, whenever an asthma attack happens, these patients can experience shortness of breath and wheeze, right? Wheezing is the classical examination finding. Okay. Now I will take you to the diagnosis later, but before that we will take a quick look at the classification of asthma into different types. There are two classification methods. One is we classify it into intrinsic and extrinsic asthma, which is mostly dealt by pediatricians, and then the other approach is to classify it based on the underlying pathophysiological mechanisms into type 2 and non-type 2 asthma. Okay, from this table they routinely ask questions. Okay, so what is this intrinsic and extrinsic asthma? When we say intrinsic asthma, the trigger factor responsible for initiation of asthma is found within the patient's body. Something from outside is not responsible. In case of extrinsic asthma, an exposure to an allergen or something from the outside world is responsible for triggering the asthma. That's why we call it as extrinsic, right? So one usual question that they ask you is which patient of asthma has a tendency for the atopy. Atopy refers to allergy proneness, who is prone to develop allergic symptoms. Obviously extrinsic asthma patients are the ones who are prone to develop the allergy symptoms. So they may have other allergies, urticaria, allergic rhinitis and other allergy related symptoms. We don't see that in patients with intrinsic asthma. Second point they will ask you is the age of onset of asthma. So most of the childhood onset asthma are going to be extrinsic asthma. Most of the adulthood onset asthma are going to be intrinsic asthma. Means that is why when an adult patient presents with asthma, it is difficult to find out for which substance they are allergic to or what is triggering, because most of them are having intrinsic asthma, right? Then the third and the most important point examiner will ask is which type of asthma is associated with Samter's triad, which you have also studied in ENT. Samter's triad refers to three symptoms, that is presence of asthma, nasal polyps and aspirin sensitivity. So when these three things come together, asthma, nasal polyps and aspirin sensitivity, we call it as Samter's triad. Samter's triad is typically seen in adult asthmatics, or in other words those who are intrinsic asthma patients. It is not seen in patients with the extrinsic asthma patients. The last point we need to know is the prognosis. So please remember, I will make an important statement. The statement is most of the childhood asthma patients outgrow their asthma by the time they become teens, right? By the time they reach teenage, they are no longer asthmatic. This rule applies to more than 80% of the childhood onset asthma. But an adulthood onset asthma, once it starts, it persists till the grave. The patients do not become asthma free easily. So that means which one has a poor prognosis? Obviously the adulthood onset intrinsic asthma carries a poor prognosis than the childhood onset extrinsic asthma. This is one classification. There is a second classification which is called as phenotypic classification, where we classify the asthma into type 2 and non-type 2 asthma. This is the most important classification that you need to know because I am anticipating MCQs on this. We classify asthma into type 2 and non-type 2. What is the basis for this classification? The basis is in the pathophysiology or in pathogenic mechanism, which helper T cell is involved. So if it is helper T cell type 2 involved, we call it as type 2 asthma. If other helper T cells are involved in the pathogenesis, we call it as non-type 2. So usually in non-type 2, it is Th1 and Th17 which are involved. In type 2, it is predominantly Th2. So these helper cells actually stimulate the production of certain cytokines. Okay, these cytokines stimulate another set of cells to come and do the damage to the airway. So what cytokines are involved in type 2? It is interleukin 4 and interleukin 5. Apart from that, immunoglobulin E also plays an important role in the pathogenesis of type 2 asthma. In non-type 2 asthma, it is interleukin 17, interleukin 1, interleukin 6. So these interleukins stimulate neutrophils. So in non-type 2 asthma, the airway inflammation is caused by neutrophils. And in type 2 asthma, these cytokines, interleukin 4, interleukin 5 and IgE, they stimulate eosinophils. So the airway inflammation in type 2 is caused by eosinophils. And type 2 is more common than non-type 2. Why this classification is important? Because we have drugs which can block these specific cytokines. So if you know the type, only then you will be able to make the right choice of biological agents. Okay. So how do I get to know whether my patient is a type 2 asthma patient or non-type 2? For that, all I need to do is once I diagnose a patient as having asthma, I have to do the markers for type 2. So if the type 2 markers are positive, it is type 2. If they are negative, then it is non-type 2. So then that begs an MCQ. What are the markers of type 2 asthma? The markers of type 2 asthma, the first one is serum IgE levels, which can be easily done in most of the basic laboratories. Apart from that, eosinophils are involved, so we can check the eosinophil count. So elevated eosinophil count, elevated serum IgE levels indicates that patient has got type 2 asthma, right? Along with that, just like when we were talking about nephro, we learnt about something called as FeNA, fractional excretion of sodium, which is used for differentiation of prerenal AKI and acute tubular necrosis. Similarly, there is also a test which evaluates the fractional exhalation of nitric oxide. Fractional excretion of sodium we used for differentiation of prerenal AKI and ATN. Fractional exhalation of nitric oxide can be used as a surrogate marker of eosinophilic inflammation. So if any tissue is invaded by eosinophils, then there will be increased production of nitric oxide. So if airway are invaded by eosinophils, then airway will be generating a lot of nitric oxide which will be exhaled, and that we can quantify. So if that is increased, again patient has got type 2 asthma. And on top of that, there is a new biomarker which has been approved in the recent times as a marker of type 2 asthma, and that is osteoprotegerine. Osteoprotegerine, it's a new biomarker. So if any of these are positive or increased, that means you have a type 2 asthma. If all of them are negative, it is non-type 2 asthma. Okay. Now what we understood so far, we understood what is asthma. Asthma is the disorder affecting small and medium airway where it causes reversible obstruction. COPD causes irreversible or persistent obstruction. Obstruction is usually triggered by airway inflammation. Inflammation can be neutrophilic, in that case it is non-type 2 asthma, or it can be eosinophilic, in that case it is type 2 asthma, and we just learnt about the biomarkers of type 2 asthma. Later we will find use of knowing those biomarkers. Okay. When a patient presents with cough, shortness of breath and wheezing, asthma is one of our differential diagnoses. The closest differential diagnosis will be COPD, especially in smokers. how do we now take it to the diagnosis? The investigation of choice for the diagnosis of asthma is always PFT. Chest X-ray has no role in the diagnosis of asthma. So why we do PFT? To understand whether there is obstruction to the airflow or not. How do we get to know whether there is obstruction or not? By looking at the FEV1 by FVC ratio. If this ratio is less than 0.7, it indicates that we have the obstruction. If the ratio is more than 0.7, that means there is no obstruction. So in asthma patients, obviously it will be less than 0.7, but COPD is also an obstructive airway disease, so there also it will be less than 0.7. So to differentiate between the two, we do a test which is called as bronchodilator reversibility test or BDR test. Bronchodilator reversibility test or BDR test. It stems from the basic principle. When we defined asthma, we defined it as an airway disease causing reversible obstruction. So if I give a bronchodilator and the obstruction gets relieved, then it is asthma. If I give a bronchodilator but the obstruction doesn't get relieved, that means there is a persistent obstruction, and that makes the diagnosis most likely COPD. So in this bronchodilator reversibility test, we administer a short-acting beta agonist to the patient. We would have already calculated patient FEV1. We give a short-acting beta agonist, and after that, if FEV1 increases by more than or equal to 12% or an absolute value of more than or equal to 200 ml, that means there is reversible obstruction. In that case, the diagnosis becomes asthma. But if there is no increase or the increase is less than 12%, that means we have persistent obstruction, and in that case, we take the diagnosis as COPD. Clear? So this is our diagnostic algorithm. Any patient with suspected asthma, do the PFT. Prove that there is obstruction by looking at FEV1 by FVC ratio. It should be less than 0.7. After that, prove that it is reversible obstruction by giving a short-acting beta agonist and rechecking FEV1. FEV1 should increase by more than or equal to 12% to say there is reversible obstruction. Various other tests can be done for the diagnosis of asthma. That includes diffusing capacity of the lung for carbon monoxide. In patients with asthma, this DLCO, see, please remember, the diffusion of gases happens at the level of alveoli. As long as alveoli are fine, the diffusing capacity of the lung for the carbon monoxide will not be decreased. When alveoli are damaged, it will be decreased. So in asthma, alveoli are not affected. That is why at least it will be normal. And sometimes because of increased vascularity, it can be increased but not decreased. In COPD, we have two types, right? Two components of COPD. One is chronic bronchitis. The second one is emphysema. What is emphysema? Irreversible dilatation of the alveoli, or in more precise words, irreversible dilatation of the respiratory acini. So if the surface where gas exchange happens, they are damaged, obviously gas exchange will not happen properly. So we will not be able to diffuse carbon monoxide efficiently. So DLCO will be decreased. Right? So what are the important tests that helps us to differentiate between asthma and COPD? First one, bronchodilator reversibility test. Second one is DLCO. Another MCQ that they will ask you is, what if there is no feasibility of doing the PFT? How can we make a diagnosis of asthma? As an alternative to spirometry, we can use peak expiratory flow rate. In patients with asthma, that will be decreased. But in patients with COPD also, that will be decreased. So again, here also we need to do the bronchodilator reversibility test. Give a short-acting beta agonist after you record the decreased PEFR. And with that, if the PEFR increases by more than or equal to 20%, it is asthma. If it does not show any increase or increases by less than 20%, then it is not asthma. Most likely it will be COPD. Okay. Now, once we have confirmed that we have a patient with asthma, how do we manage? So for management of asthma, we follow the GINA guidelines, and fortunately the 2024 GINA guidelines are no different from the 2023 GINA guidelines. So for a patient with asthma, we generally have two kinds of medications. One is called as a reliever, which is generally taken whenever an asthma attack happens. And the other one is called as a maintenance medication, which is usually taken to prevent the asthma attack from happening. So a reliever generally will be a short-acting beta agonist because it acts quickly, right? The onset of action is fast. And a maintenance medication is usually a combination of long-acting beta agonist and an inhaled corticosteroid. Long-acting beta agonist to prevent the bronchoconstriction and inhaled corticosteroids to take care of the airway inflammation. But today what we do is, for most of the patients, we give a prescription of a combination of formoterol and inhaled corticosteroid. The reason for that is formoterol is rapid in onset just like SABA, and it is long acting just like any other LABA. So that relieves a lot of confusions in patients who are facing asthma. So what we do now is, for most patients, we treat them with a combination of formoterol and inhaled corticosteroid. Why formoterol is chosen? Because it is a rapid onset LABA. It is a rapid onset long acting beta agonist. Rapid onset LABA. Clear? Okay. Now, I told you we treat with formoterol plus inhaled corticosteroid combination. But there is some point to understand here. For some patients, we give them as and when required medication. For some patients, we put them on a regular maintenance treatment. Means those patients who are on as and when required medication, they will take one puff of the inhaler whenever an asthma attack happens. And those patients who need more frequent medication, they take inhaler morning, evening regularly. So when they take inhaler morning and evening regularly, we call it as MART, or maintenance and reliever therapy, or MART. When they take as and when, we can call it as SOS treatment or PRN treatment or as and when treatment. Now, how do we decide whom to give as and when required and for whom to give a regular treatment? For that, all you need to do is, whenever they give a clinically oriented question, try to find the answers for this question from the description. Whether the patient is having asthma attacks on most days. Most days means refers to more than or equal to 5 days per week, or in other words, more than 4 days per week if patient is having asthma attacks, or even if patient is having a single nighttime asthma attack. So these are the two informations I need from any given clinically oriented question. For these questions, if the answer turns out to be yes, then those patients require regular medication. Those who are experiencing even one nocturnal or nighttime attack per week, or almost all days, right, 5, 6 days or 7 days, they are experiencing asthma attacks per week. In such cases, they require the maintenance and reliever therapy. Those who are experiencing less frequent symptoms, right, they will require as and when treatment. They don't need a regular treatment. Now, for those whom we have decided that we are giving them SOS treatment or as and when required, take an inhaler, we give them a combination of formoterol plus low dose inhaled corticosteroid. But for those who require the maintenance treatment, those who are experiencing 5+ episodes per week or one or more than one nighttime episodes per week, for them, we might have to either start with low dose inhaled corticosteroid and formoterol combination, or the medium dose inhaled corticosteroid and formoterol combination. So we have to decide whether the steroid component of this inhaler will be low dose or medium dose to start with. On what basis we decide that? By looking at the FEV1 value of the patient. If the FEV1 is more than 30% of the predicted value, more than 30% of the predicted value, then we can treat them with the low dose inhaled corticosteroid and formoterol. But if the FEV1 is less than 30%, that means that's a very bad scenario, right? So in such cases, we treat them with a combination of formoterol plus steroid becomes medium dose. So any patient with asthma, once diagnosed, will either be started on as and when required formoterol and inhaled corticosteroid low dose combination, or the maintenance and reliever therapy. If you are giving maintenance and reliever therapy, whether the steroid will be low dose or medium dose, that will be decided based on patient's FEV1. More than 30%, low dose. Less than 30%, then medium dose. This is a starting point. Once we start this, if the asthma symptoms are controlled, good. If asthma symptoms are not controlled, we need to step up the treatment. So what all step up we can do? If the patient is not controlled, right, with the MART also, then we would have started with maximum medium dose inhaled corticosteroids. Agar usse control nahi hota hai, to then we can go ahead with the high dose of steroid. That is one option. Or we can add a long acting antimuscarinic agent like tiotropium, right? Apart from that, we have these monoclonal antibodies which are highly effective, and we need to make a right choice about the monoclonal antibody to derive that effectiveness. And that is why knowing the type 2 and non-type 2 status becomes important. That is why any patient diagnosed with asthma, we should do their IgE levels, absolute eosinophil count, or the osteoprotegerine or FeNO to understand whether it is type 2 or non-type 2, right? If it is type 2, there is a long list of medications which are useful. Omalizumab, which is anti-IgE, that can be used, or dupilumab, which is anti-interleukin 4 receptor, that can be used, or mepolizumab or reslizumab, which are anti-interleukin 5, they can be used. Then we have benralizumab, which is anti-interleukin 5 receptor, or the newest drug available from last 2 years, that is tezepelumab, which is anti-TSLP. These all can be used for a patient with type 2 asthma. But it is only the tezepelumab which can be useful for a patient with non-type 2 asthma. This is a potential MCQ point lingering around for some time. They have asked about it once in the NEET SS, once in the INI CET, and either in this NEET PG or FMGE they are going to ask this point. So please remember tezepelumab, which is a monoclonal antibody against TSLP, anti-TSLP monoclonal antibody, which can be used for type 2 as well as non-type 2. Everything else can only be used for type 2. Now another pharmacology question that they can ask you is monoclonal antibody and its target antigen, right, or its target cytokine. So for that, let me make it a bit easier for you to remember. Omalizumab, I think we need to kind of remember it because it is anti-IgE, and this is the first monoclonal antibody that was made available for treatment of asthma patients. Everything else is relatively new. How to remember dupilumab? D is the fourth letter of alphabet. That way you can remember that dupilumab is for the interleukin 4 receptor. Everything else are targeting interleukin 5, right? Everything else is targeting interleukin 5. And tezepelumab, you can remember TSLP, tezepelumab, T for T. So that way you can remember it. Okay, so that's about asthma. Now I will take you to the next topic, which is COPD. COPD is also an obstructive airway disorder. How is it different from the asthma? Most important difference is that the obstruction here, right? The obstruction here is reversible. So this is a disease of the airway affecting large, medium and small airway, where it causes persistent or irreversible obstruction. In asthma, we have reversible obstruction, persistent or irreversible obstruction. That is a main differentiating feature. Okay. Then COPD not only affects the airway, asthma only affects the airway, but COPD also affects the lung parenchyma in the form of what we call as emphysema. So the airway involvement, we call it as chronic bronchitis, and the parenchymal involvement, we call it as emphysema. Okay. Now what are the risk factors for COPD? The most common risk factor for COPD is smoking. It accounts for more than 90% of the cases. And the impact of smoking depends on the number of cigarettes smoked as well as the duration of smoking. So to understand the gravity of smoking and its consequences, we might have to know what is called as pack years. How do we calculate pack years? Pack years is calculated by number of packs of cigarettes smoked per day into number of years smoked. So it is number of packs of cigarette smoked per day, and when we say pack, it refers to international pack. So one international pack is equal to 20 cigarettes. 20 cigarettes. So if a patient is smoking 10 cigarettes per day, that means he is smoking half a pack per day, right? So number of packs of cigarettes smoked per day into number of years smoked, that gives us the pack years, right? So the risk of COPD is high when patient has got more than 15 pack years, and the risk of carcinoma of the lung is more when patient has got more than 30 pack years, Okay, clear? Okay. Then another MCQ they will ask you is, we see plenty of females who do not smoke but still develop COPD, and one of the common mistake that we do in the examination hall is that we take the answer as the passive smoking. No, passive smoking increases the risk of the carcinoma of the lung, but the impact on COPD is minimal. Passive smokers generally don't develop COPD because for us to develop COPD, we need active exposure of at least 15 years, right? A passive exposure is generally not sufficient enough to push us towards the COPD. Then why do these females develop the COPD? It is because of burning the biomass fuel, जो चूल्हा जलाते हैं उससे जो smoke निकलता है, that can also be the reason for COPD. And I think all of us know that genetics also contributes to the pathogenesis of COPD, that is alpha-1 antitrypsin deficiency. More than bronchitis, it causes emphysema. And that begs one important question. Emphysema can cause by smoking related COPD, and emphysema can happen because of alpha-1 antitrypsin deficiency related COPD. But both of them are not same. There are some differences. So they will ask you which lobe is predominantly affected in alpha-1 antitrypsin deficiency related emphysema, and which lobe is predominantly affected in smoking related emphysema. So in alpha-1 antitrypsin deficiency related emphysema, lower lobes are predominantly affected. Lower lobes are affected. And in smoking related emphysema, it is the upper lobes. In smoking, it is the upper lobes. How to remember it? I have a simple hack. When we smoke, we feel high, so think of high or upper lobes. When someone is given a genetic diagnosis that you're suffering from a genetic disorder, we feel very low, so think of lower lobes. Alpha-1 antitrypsin deficiency is a genetic disorder. So if it is diagnosed, obviously you will feel low, so think of lower lobes. Smoke, you feel high, so think of upper lobes. Okay. Now, what are the clinical features of a patient with COPD? We have two components in this, chronic bronchitis and emphysema, right? What is chronic bronchitis? Bronchi, right? When we say bronchi are being inflamed here. That's why we're using the term bronchitis. And when bronchi get inflamed, it leads to production of the persistent obstruction and cough. So the definition of chronic bronchitis goes like this: productive cough. Productive means with sputum production. Asthma, not much sputum production or very scanty, thick, viscid sputum production. Here, generous, copious amount of sputum production. Productive cough for more than or equal to 3 months per year for 2 consecutive years. 2 consecutive years means this year also 3 months of cough, next year also 3 months of cough, then we will call it as chronic bronchitis. These patients with chronic bronchitis are usually called as blue bloaters. Blue bloaters. Why are they called as blue bloaters? Because generally they develop cyanosis. Why are they developing cyanosis? Because of the persistent airway obstruction, less amount of oxygen is able to reach the alveoli and we are not able to completely oxygenate the blood. That is why we develop the cyanosis. Okay. Then we have a second component which is called as emphysema, which is defined as irreversible dilatation and destruction of the respiratory acini. Respiratory acini includes alveoli plus alveolar duct plus the respiratory bronchiole. All of this put together we call it as one acinus, right? So when acini get dilated, we call it as emphysema. In some books they just simply mention the dilatation of alveoli, which is acceptable, but more precise thing is irreversible dilatation of the acini. So when acini get dilated, they trap more and more air, and because your airway is obstructed, air comes in, gets trapped in this dilated acini, cannot leave it, right? So because of that, the lung starts expanding in size and it leads to various manifestations. Technically, patients with emphysema are called as pink puffers. They are called as pink puffers because their lungs are puffed, and because they are not cyanosed, we call them as pink puffers. What consequences this leads to? Most importantly, this leads to difficulty in exhalation of the air. Air goes in and gets trapped in your alveoli, which are dilated, and you are not able to exhale it. So that leads to shortness of breath. And to make it easy to exhale, these patients breathe with the pursed lip. We call it as pursed lip breathing. Pursed lip breathing. To again facilitate the exhalation, these patients assume a posture which is called as tripod posture, where they generally lean forward and rest their elbows on the thigh and breathe. We call it as tripod position, like you see here, tripod position. Okay. Now another finding you can see in these patients is because the lungs are getting trapped with air because of the emphysema, lungs start expanding in size. The expanding lungs cannot expand horizontally because the rib cage becomes a restricting factor. The ribs are anteriorly and posteriorly attached. So only way we can expand the chest is antero-posteriorly. So patient's antero-posterior diameter of the chest starts expanding. Normally chest looks like this in a cut section. But once the antero-posterior diameter starts expanding, it becomes more spherical. That is what we call as the barrel-shaped chest or barrel shaped chest. Okay. Now these patients, because of tripod position, they're repeatedly resting their elbows on the thighs, and that leads to hyperpigmentation of the thigh. So this thigh hyperpigmentation is what we call as Dahl sign. This tripod position, sometimes an image of a patient with pursed lip breathing, that or the Dahl sign, they can come as image based questions. Image based questions. Okay. There's one more sign which is called as Hoover sign, which is seen in severe COPD. It is generally not seen in mild COPD patients. It is a sign of severe COPD. What happens here? These patients with extensive emphysema, sometimes during inspiration, the intercostal spaces, especially the lower intercostal spaces, are indrawn. Normally what happens during inspiration, the intercostal spaces expand, right? They grow outwards. But here, these patients, there is intercostal indrawing. In the exam, they tend to confuse you, saying that Hoover sign represents inspiratory indrawing of intercostal spaces, right? Expiratory indrawing of intercostal spaces, right? They can try to confuse. So the easiest way to remember it is remember all eyes. It is inspiration indrawing, not outdrawing of what? Intercostal spaces. Inspiratory indrawing of intercostal spaces. That is what we call as Hoover sign. Okay. So these are the clinical signs. Once clinically we have suspected that the patient may be having the COPD based on the smoking history and the other findings we just studied, how do we make the diagnosis? For asthma, there was no role of X-ray. It was purely PFT based. If PFT was not possible, peak expiratory flow rate is what we were doing. But for COPD, we can consider imaging because emphysema can be documented on imaging, and the chronic bronchitis can be assessed on the grounds of history, that is 3 months of cough per year for 2 consecutive years, and the persistent obstruction can be demonstrated with the spirometry or PFT, right? So chest X-ray, how the emphysema is going to look. Your lungs are expanded in size, right? Because of that, the diaphragm will be pushed down, rib spaces will be widened, and the mediastinum will be more pushed inwards, right? So that leads to 2 important findings. What are those? Because the diaphragm is pushed down, it loses its dome-like appearance. The normal chest X-ray shows that diaphragm appears like the dome. There is a right hemidome and the left hemidome. That dome is flattened, right? So this is what we call as the flattened dome of diaphragm. Flattened dome of diaphragm. The other thing is a tubular heart. Because the mediastinum is compressed by the expanded lungs, the heart looks like a tube. So we call it as tubular heart. Tubular heart and flat diaphragm. These are 2 important X-ray findings. Yes, apart from that, air generally on the X-ray looks black. So you will have more blackish lung fields with hypovascularity, as Shubham or Sachin pointed out. But because it is a function of exposure, slightly under exposure or over exposure can change the way the lung look, right? In fact, when you look at these 2 images, this looks much darker, a normal X-ray, than this, because it also depends on the exposure. So that is why for identification of emphysema, the most trustable findings are a tubular heart and flattened diaphragm. Okay, so that helps us to recognize emphysema. Apart from that, pyrometry is the gold standard. In the spirometry, obviously chronic bronchitis would have obstruction. So when we look at FEV1 by FVC ratio, it will be less than 0.7. That only proves that you have got obstruction. To prove that it is COPD, we have to prove that the obstruction is persistent. So we will do the bronchodilator reversibility test. If it was asthma, there will be more than 12% jump in the FEV1. In a patient with COPD, there will be less than 12% jump. Right. Another test that can be helpful is DLCO, that will be decreased in patients with COPD. Clear? Okay. Now once we have diagnosed it, right, how do we manage? For management, we rely on the GOLD guidelines. Okay, there are a few things here. One is GOLD strongly recommends certain vaccines for a patient with COPD, and that can be asked as an MCQ. Which of the following vaccine is or is not recommended for a patient with COPD? Second thing, just like asthma, we start the treatment at some level, right? So what should be the initial treatment? How we decide the initial treatment? Okay. So what are the vaccines recommended? One of the problems of COPD patients is repeated exacerbations, and the most common reason for repeated exacerbations is infections. At least some of the infections which are seen in COPD patients are vaccine preventable, so we tend to offer them vaccines. The most common infection responsible for exacerbation is the pneumococcal infection, and we have a vaccine for that. So that is why pneumococcal vaccine is recommended. A polyvalent pneumococcal vaccine covering 23 strains, what we call as Pneumovac 23, is recommended. Apart from that, seasonal flu or influenza is also an important reason for the COPD exacerbation. That is also vaccine preventable, so that is recommended. Pneumococcal vaccine is given only once in a lifetime. We don't need to give it annually. So once you diagnose the patient as having COPD, give one jab and done. But influenza vaccine, because the influenza, the H1N1, H5N1, they tend to mutate, we need to give it yearly, right? It is an annual vaccine. COVID-19 vaccine was recommended during the COVID phase. Currently, there is no active recommendation, but all the COPD patients were given the COVID-19 vaccine on a preferential basis during the COVID peaks. And from 2022, there is a newly recommended vaccine, which is the pertussis. The main reason was to cover pertussis, but because pertussis vaccine is not readily available as a solo vaccine, we give the diphtheria, tetanus, pertussis. Right? It's a newly recommended vaccine. So they can ask you a question, which of the following vaccine is newly recommended for a patient with COPD? Either they will mention diphtheria, tetanus, pertussis, or they will directly mention pertussis. You should be able to pick it up. The usual recommended vaccine is DTaP, that means diphtheria toxoid at reduced dose, right? Tetanus toxoid at regular dose, and pertussis toxoid at regular dose, but the acellular pertussis vaccine. Acellular pertussis vaccine. Okay, so after vaccination, what will be the initial prescription for a patient with COPD, right? That is about inhalers. So for that, according to GOLD guidelines, we have to put the patient in three possible categories, category A, B or E. Now how to decide the category? Generally they will have a clinical story in the MCQ. So read through that story and from the story find the answers for these questions. So in last 1 year, whether patient had 2 or more than 2 moderate exacerbation or more than or equal to 1 severe exacerbation. What is moderate exacerbation? Moderate exacerbation is the one which required the consultation with a physician or a doctor and modification of patient treatment, and a severe exacerbation is the one that required the hospitalization. In your exam, most of the times they will not give you the story, they will directly mention patient had 2 or 3 or 4 or 1 or 0 moderate exacerbation in the past. But the severe exacerbation, they may not call it a severe exacerbation, they might just mention that 3 months back, 6 months back patient was admitted. So in last 1 year's history, a patient had to go to the hospital twice or more than twice to see a doctor and get his treatment modified, or if he had to get admitted once or more than once, right, then the patient goes into category E. It's easy to remember because when you look at this story, what is the story focusing on? The story is focusing on exacerbation, right? So if the patient's main problem is exacerbation, he should go into exacerbation category, that is category E. But if in last 1 year there were no exacerbations, or there were exacerbations but mild, or there were exacerbations which were moderate but not more than 2, like 1 moderate exacerbation in last 1 year. So in that case, for this question our answer is going to be no. Our answer is going to be no, right? So in that case, how do I categorize the patient into A and B? E is very clear. In last 1 year, at least 1 admission or 2 hospital visit requiring treatment change, category E. But if no admission, right, less than 2 hospital visits or no hospital visits, then whether to put it in category B or category A will be decided by the severity of shortness of breath or dyspnea using a scale called as Modified Medical Research Council grade or MMRC grade. If the MMRC grade, generally the grade is 0 to 4, right? If it is 0 to 1, that means mild shortness of breath, we will put the patient in category A. And if more than or equal to 2, then category B. Now based on the category, how will we decide the initial choice? So for category A, this patient does not have significant exacerbation, right? No major exacerbations. At the same time, no severe shortness of breath. So for them, we don't need to do a polypharmacy. We need to give only 1 medication. So either LAMA or LABA you can choose. You can treat them with any bronchodilator. But for category B and category E patients, category B patient, dyspnea is the concern, right? And for category E patient, exacerbation is the concern. For these patients, we treat them with both LAMA plus LABA. LAMA plus LABA. Shubham, good. So all the scoring systems, right? We will do a quick session because many of you might need to memorize them. So towards the exam, I will share you a 2 or 3 page document which will have all the important scores or scoring systems that you need to know for your exam. That will include the 𝐒𝐿 65, MMRC grade, ABCD to score, CHA to DS to VAS score. So we'll do that separately. Okay. So this kind of completes our initial approach to COPD. Okay. Now the next thing we need to know is all that we spoke, right? We gave vaccine that will reduce exacerbations. We started them on LAMA plus LABA or LAMA or LABA depending on category A hai ya B hai ya E hai. But these will only make the patient's quality of life better. Their shortness of breath will come down, exacerbation frequency will come down. That will not reduce the mortality. So they will ask you one last question. Which of the following intervention or treatment reduces the mortality in patients with COPD? Most of the patients with COPD, because of long-standing hypoxia, right? Because of long-standing hypoxia, develop the pulmonary hypertension, right heart failure, and eventually die because of a cardiovascular cause. But if I take care of the hypoxia, then at least the cardiovascular mortality can be reduced. So that is why long-term oxygen therapy reduces their risk of mortality. Okay, clear? So that's about the COPD. We have one small extra topic. We will take just 10 minutes on it, and that is the obstructive sleep apnea. Generally, I have not addressed this in the offline classes because this was primarily an INI CT topic, then slowly drifted into the NEET PG, and now I am expecting that this will drift into the FMGE, right? So we'll understand what is it. Obstructive sleep apnea is a condition where patients have fragmented or broken sleep. Means sleep is broken, right? Not a continuous happy sleep. Fragmented or broken sleep, which is non-restorative. What does that mean? Means when you get up, you don't feel fresh. You feel like sufficiently soya nahi hu main, right? And this is happening not because you were thinking about tomorrow exam hai kaisa hoga. That is a different story, right? We can experience insomnia because of so many reasons. Here, there is no insomnia. They have tried to sleep, they have slept, but it was either broken or non-restorative due to complete or partial collapse of the airway. Means when they sleep, right, the airway collapses either completely or partially. And when airway collapses, obviously the air from outside is not going to go well into the lungs. So that will result in hypoxia. Okay. So why the airway collapses? Because normally when we go to sleep, the tone of the muscles of the airway or the tone of the whole body comes down. So muscles contraction decreases. So slightly it collapses. Slight collapse should not cause a problem for a normal individual. But if you have an anatomical abnormality of the neck, right, your jaw is micrognathia, small jaw, short neck, obesity, right? So in all those cases, it becomes a problem because whatever small drop may be sufficient enough to reduce the flow of air through that collapsed airway. So when we go to sleep, the tone of the muscle decreases, airway collapses, coupled with the anatomical factors, airflow starts getting limited. So once the airflow starts getting limited, the oxygen level starts dropping, right? Once the oxygen level starts dropping, your respiratory center gets triggered when it drops down to certain level. So once the respiratory center gets triggered, it will wake you up because it needs to now increase the respiratory effort. So it will activate sympathetic nervous system and the wakefulness center, and we wake up. Once we wake up, the sleep is broken. Once I wake up, the muscle tone increases, the collapsed airway becomes normal. I will feel breathing easily. I'll go back to sleep. Once I go back to sleep, the muscle tone drops, the airway collapses, hypoxia happens, I wake up again. So patient throughout the night goes through these cycles of waking up, sleeping, waking up, sleeping. So because of that, when he gets up in the morning, either he will report that there is fragmented sleep. Second thing, when the airway collapses and air passes through that collapsed airway, we will hear snoring, right? We will hear snoring. Now, if I did not have a good sleep quality because it was broken or fragmented, obviously during daytime I feel sleepy, right? No matter what circumstance I feel sleepy. So the typical clinical features are broken sleep, snoring, and increased daytime sleepiness. So whenever we have a patient complaining these, how do we diagnose the OSA? First, we screen whether this is likely to be OSA. So what is the tool used for screening? That can be asked as an MCQ. So there are two tools. One is called as Stop Bang Questionnaire and the other one Epworth Sleepiness Scale. Any of them can be used, but most commonly used is the Stop Bang Questionnaire. Stop Bang Questionnaire. So we ask the patient whether they have any of these symptoms. Stop bang itself is a mnemonic, right? So here S refers to snoring, T for tiredness, right? A for observed apnea. If you have a partner, whether she or he has seen you stopping breathing during sleeping, okay? Then P here refers to hypertension or BP, high blood pressure. B for high BMI, right? I told you obesity, too much of fat around the neck can collapse the airway, right? Then age of the individual more than 50 years, neck circumference larger means more fat is there around it, and the gender, especially males are more prone to develop it. Okay, so Stop Bang Questionnaire can be used as a screening tool or the Epworth Sleepiness Scale. Do I need to remember the components of the Stop Bang Questionnaire? The answer is no. They won't ask you which of the following is not part of Stop Bang Questionnaire and all. If they ask you, they will ask you which of the following tool is used as a screening tool for obstructive sleep apnea: Stop Bang or Epworth Sleepiness Scale. Okay. Now, based on the Stop Bang Questionnaire, if I am suspecting that patient may be having OSA, how do I reach the diagnosis, right? So for diagnosis, the investigation of choice is polysomnography. Polysomnography, right? Absolutely right. Polysomnography. That the Stop Bang, Epworth, they are all screening tools to identify for which patient we should do further investigation. It is not for diagnosis. Once you come to the conclusion that based on the Stop Bang it is likely to be a case of OSA, we do the further investigation, that is going to be polysomnography. So what do we do in polysomnography? We will assess the whole one night's sleep. How many times patient had an episode of hypoxia, how many times patient had cessation of breathing. Okay. So for that we need to calculate some things called as apnea hypopnea index. Apnea hypopnea index or AHI. Okay. So how do we calculate that? The patient's number of apneas that he had during sleep and number of hypoapneas he had during sleep, right? Apneas plus hypoapneas divided by the total number of hours of sleep. So in other words, it is the number of apnea plus hypopnea episodes happening per hour of sleep. How many apneas and hypoapneas happen during 1 hour of sleep? Then they will ask you, how do you define that a particular event was apnea or hypopnea? So we need to understand these two terminologies. Here apnea refers to more than 90% decrease in the airflow for more than 10 seconds. So during the sleep, if the airflow through the airway drops down by more than 90%, let me say it was flowing 1 liter per minute, dropped to less than 100 ml per minute, and that drop sustained for 10 seconds or more, such an event will be called as apnea. And what is hypopnea? More than 30% decrease in the airflow, more than 90% for 10 seconds is going to be apnea. More than 30%, not like 90%. 30%, 40%, 50%, 60%, 70%, anything up to 90% decrease in the airflow, 30 to 90% decrease in the airflow with more than 4% decrease in SpO2. Airflow कम हुआ, SpO2 dropped by more than 4%. Like 98 था 93 हो गया, that is definitely more than 4% drop. That will be called as hypopnea. So in 1 hour of sleep, how many episodes of apnea happened and how many episodes of hypopnea happened? Based on that we come to the diagnosis. So if the patient had more than or equal to 15 apnea hypopnea index, right, AHI, this is the AHI. If it is more than 15, that diagnoses the case as the obstructive sleep apnea, even if patient does not have symptoms. An asymptomatic patient, if apnea hypopnea index is more than 15 per hour, you don't need to have symptoms, still you have obstructive sleep apnea. Okay, but if patient has symptoms like increased daytime sleepiness, right, or the waking with the breath holding spells, gasping or choking, or if the patient's partner say that patient has loud snoring or has hypertension or other consequences of obstructive sleep apnea, if they are present, then AHI more than or equal to 5 is enough, right? So let me summarize that again. For diagnosis, right, AHI more than or equal to 15 per hour, right? So it is obstructive sleep apnea even if no symptoms present. But if symptoms are present, then all we need is more than or equal to 5 AHI, apnea hypopnea per hour. If more than 5 AHI per hour with symptoms, then it is obstructive sleep apnea. If no symptoms, then we need more than 15. Okay. Now, based on the AHI itself, we can also categorize the severity of the OSA. If it is more than 30, more than or equal to 30, it will be counted as severe, right? And if it is 15 to 30, it will be considered as moderate. And if it is 5 to 15, it will be considered as mild. Remember, 5 plus only when if it is with symptoms, we would have diagnosed, right? If without symptoms, this is not even diagnosed as the obstructive sleep apnea. More than 15, we don't need the symptoms, we directly diagnose it. 15 to 30, moderate, more than 30, severe, and 5 to 15, it will be counted as mild. Why examiners are giving the importance for the obstructive sleep apnea in the recent times? Because it is almost taking an epidemic proportions, and this is a relevant disease for India today. Whatever is important for the society becomes important for the exam. Why is it important? Because patients with obstructive sleep apnea overall are at increased risk of mortality. Obstructive sleep apnea increases the risk of hypertension. Why? Because when we are experiencing these obstructive episodes, sympathetic nervous system is getting activated. So that pushes the blood pressure higher. Okay. Then daytime, we are tired and fatigued, right? So that tired and fatiguedness again to activate or make us wakeful, again sympathetic nervous system gets activated. So our BP can be higher. Okay. This also leads to pulmonary hypertension, because whenever there is hypoxia, pulmonary vasculature contraction happens. So pressure inside the pulmonary artery increases. Increases the risk of ischemic heart disease, increase the risk of stroke, increase the risk of diabetes mellitus, again related to sympathetic nervous system activation. Whenever sympathetic nervous system gets activated, gluconeogenesis, glycolysis, all that happens. So we can have increased risk of type 2 diabetes mellitus. Patients with obstructive sleep apnea have increased risk of road traffic accidents, because night sleep was not restorative, daytime they feel sleepy, they can dash somebody. And overall, it leads to poor quality of life, right? So these are the important reasons why obstructive sleep apnea needs to be diagnosed and treated. We screen with stop bang or Epworth, then we diagnose with polysomnography, that is the investigation of choice. 15 or more than 15 AHI without symptom also is OSA, and 5 or more than 5 AHI with symptom, it is OSA. Once we have diagnosed, how do we manage? The treatment of choice for any patient with obstructive sleep apnea is the positive airway pressure, or CPAP, continuous positive airway pressure. CPAP is the treatment of choice. Okay. Apart from that, if there are anatomical abnormalities, that can be surgically corrected. Okay. And equally important is weight loss. Weight loss does help reduce the obstructive episodes to some extent, and mainly to make them awake or wakeful during day, reduce the daytime sleepiness. To increase the alertness during day, we can use stimulant drugs like modafinil and methylphenidate. Modafinil and methylphenidate. Yes, it is a risk factor for atrial fibrillation also. See, mainly the drugs which alter the cardia, right, in the form of hypertrophy. If you are causing hypertension, you will develop the left ventricular hypertrophy. Eventually, you will develop the left atrial hypertrophy. Once you have left atrial hypertrophy, atrial fibrillation does happen. Yes. Orlistat is not routinely used these days because its efficacy is minimal, right? We have much better drugs. Currently, the drug that is most commonly used for the pharmacotherapy of obesity or weight loss is the GLP-1 analogs like liraglutide and semaglutide. So from the respiratory side, this much I had. We will take a quick break, and in another 20-30 minutes we will restart with the rest of the topics. Okay. Someone was asking me about the PYQs. We have a document of all the important PYQs from the FMGE. If you want, I will put it on the Telegram. You can go through them. Okay. So see you in another half an hour, guys. See you. Bye bye.